Okay, good afternoon. Thanks for joining us for MedHeads. This is Stephanie Baum. I'm the digital health editor with MedCity News, and I'm based in this week in East Bay, California, having come out to cover a conference, Health 2.0, as well as the Rock Health Summit and the Stanford Medicine X conference. And I'm joined by my colleague Neil Versel in Chicago, who's our health technology reporter, who himself has just returned from a conference of his own in DC at Health IT Week, where I believe you moderated a panel.
Mm-hmm. Yeah, I was on a panel about patient engagement about interoperability last week, when I was on a panel about patient engagement.
It's difficult to keep up.
Yeah, exactly. This week was interoperability at the SureScripts annual user meeting. I also did go to the HIMSS Policy Summit up on Capitol Hill, and I see you're in the same spot you were in last week. I'm back in the same spot I was in last week. So obviously we both got in some quality family time as well with our trips.
Yes, we did.
We did.
I did anyway.
I did
too.
But
yeah, that's right. Because your mom lives down in DC.
That's correct.
So this week we are talking about another conference that Neil's about to go to.
It is conference season.
It is conference season.
Megan was at something. Nicole was at something. Yeah, we were all.
That's right.
Yeah.
We're all on the road. So this week we're going to be talking about CHIME, which is the College of Healthcare Information Management Executives. And I have to be honest, it's not an acronym I hear being bandied about all that often. And I've only been covering healthcare and digital health for like the past 4 years, but Neil, you've been doing this far longer than I have. I mean, I generally hear when I encounter chief information officers, they generally talk about their business and other CIOs, but I definitely don't hear them dropping CHIME that often. What about you?
Okay. Well, I hear it a lot because I cover health IT more closely than anybody else on this staff, and probably more closely than all but about 10 to 12 other reporters in the country. So, so yeah, I hear it a lot. It is one that I've said to you and to Chris Sepper, our esteemed editor, that it is something that's undercovered. A lot of you don't get a lot of press there, which is one reason why I like going there, because there's less competition for good stories.
Okay.
You also get, you get a lot of FaceTime with hundreds of CIOs. You get FaceTime with a lot of vendor executives. You get to see a lot of the behind-the-scenes stuff, although some of the behind-the-scenes stuff is officially off the record. They have, for example, vendor focus groups. They have 2 afternoons of that where 2 sessions of about an hour and a half each for 2 consecutive days, where vendors pay a whole lot of money to convene focus groups with a select group of CIOs to run their products and their ideas by them and get the feedback. Only in the last 6 or 7 years or so has CHIME let the press into these. They used to be off limits, so we would go and hang out at the pool or something, because these are usually at nice resorts and somewhere warm, and next week is going to be Orlando.
Sure. So there's a comfort factor that's happened because
there's a comfort factor, absolutely.
Okay.
Yeah.
Well,
but these focus groups now, they do open them up to the press now. Only 1 reporter maximum per session. Vendors do not have to allow the media in. But anything said in there is mostly off the record. We're allowed to report on ideas and themes. We're not allowed to name people by name or quote them directly unless we go and talk to them one-on-one afterwards. So
that sounds like a challenge.
Yeah, it is a challenge, but it also gives you, it's a good exercise in watching the sausage making of healthcare and healthcare policy and product development and that sort of thing.
It's true, you get a lot of insight.
Yeah.
Okay. Well, now both of us have had a look at some of the priorities for CHIME in 2015, and given the fact that we're in the 4th quarter now, and given the fact that you're about to go to this conference, what do you think any of those priorities that they set for 2015, what do you think they're going to be? Have there been any home runs that they're going to be, are they going to be doing any victory laps over any of them?
And that's a good question. Well, let's run down what the priorities are. I'm looking at their website right now, and they listed, they had kind of one sheet, one page lists, one page descriptions of each one, but their policy priorities for 2015 were taking care of patient identity matching. Obviously, that's got a long way to go. Cybersecurity and healthcare was one of their priorities, and that was even before we started seeing malicious hacks from state-sponsored attackers earlier this year. The EHR incentive program, meaningful use, obviously some news on that this week. Patient safety and regulatory oversight of health IT. And telemedicine and telehealth was another priority. Clinical quality management, ICD-10, and interoperability. I'm going to say the one thing that they're probably happiest about is ICD-10, because as you know, as our readers know, and as viewers know, ICD-10 finally went into effect on October 1st after a couple of years of delay. CHIME was one of the most irate groups when it was secretly snuck into the last-minute doc Medicare Band-Aid last year to delay ICD-10 another year legislatively, a year after CMS had done it with a regulatory, through a rulemaking. So it was supposed to take effect in 2013. Then it was supposed to take effect in 2014 before Congress intervened, really behind closed doors. And they were just livid about this because they had done so much work, put so much money and so much time into getting their organizations ready for ICD-10, and all of a sudden they were told, well, let's slow down, we're going to wait, we're not going to do it yet, even though we've done all this prep, we've even trained people on how to do it. The opposition to switching to ICD-10 came from smaller providers, individual
because
physicians.
It was too much of a cost? Or
too much of a cost, too much of a burden, and of course they don't have full-time IT staff. The CIOs are the full-time IT staff, and they run the IT shop at hospitals and health systems. So the fact that it did go into effect, and there seem to be, there have been a few glitches, but it seems to be pretty smoothly, has gone relatively smoothly. I think a lot of people are now, a few people I've heard compare it to Y2K, where there was a lot of preparation, a lot of money spent, a lot of time spent, also a lot of predictions of doom and gloom, and hospitals nothing shut down.
Sure.
Things might have slowed down. There might have been a handful of small hiccups. We're still hearing about small hiccups too. Also, I don't think the first Medicare payments have gone out since ICD-10 has taken effect either. So there may be something happening there in the next couple of weeks when those payments go out.
Sure.
But CHIME has to be very happy that it's finally, that the transition's finally happened.
Sure. But on the flip side, we're going to look at things that they might be pretty disappointed about, that have made relatively little progress. It seems like interoperability is among them.
Oh yes, interoperability, and I reported in the last couple of weeks.
That's right. The interoperability roadmap.
This week, ONC finalized the interoperability roadmap, and that was an interesting day. On, I believe it was Wednesday. No, it was Tuesday when that came out. They called it noon Eastern Time press conference with a 4:15 p.m. embargo, which is a weird time to have an embargo. Well, it's because they were speaking at, ONC was at some event that I was not at. It was in D.C., but I was not there. Right. For some reason, the news obviously got out to the people in the room there that this roadmap was coming out. So we had we had a few hours to get our stories written. So reporters were briefed then. But then right at 4:15, we find out that bigger news is coming at 4:30, or I found out even later because I, for some reason, didn't get the media advisory, and that's that the stage 3 meaningful use rules came out, as well as the modification were final, including the modifications to stage 2. So obviously interoperability is a problem. Everybody in the patient space is saying we got to get this interoperability done. Politicians are leaning on healthcare to get their act together with interoperability. ONC and HHS have been leaning on everybody. You know, they have been complaining about information blocking.
Sure.
A lot of that's been taken to mean vendors, but I've heard some people say recently that information blocking is that CIOs, hospitals, healthcare providers are at least as culpable as the vendors for not being more insistent on the vendors making their systems interoperability, and also because
So
under
just being poor negotiators, basically.
well, some being poor negotiators, but also not really having the business case for interoperability and for really protecting their turf because they don't want to share data with their competitors unless they have to.
Yeah, I mean, looking at it with some of the sort of the top priority of the roadmap from 2015 to 2017, be able to send and receive data to improve patient safety and care outcomes.
Correct.
I guess there's something for everyone there. But how difficult do you think that's going to be to achieve compared to sort of some of the other things? And what do you think? I mean, CHIME has a voice in all this, you know, based on the power of their members. How influential do you think they've been at getting those priorities ironed out?
I think the CIOs want the information to flow. It may be the people above them. It might be the CFO and the CEO who don't want to lose business to competitors. Now, the shift toward value-based payment and the growth of accountable care is changing that. And, you know, of course, Medicare is accelerating its own shift to value-based payment, and that was noted in the interoperability roadmap. In effect, Karen DeSalvo said that this is the sort of the companion piece to that is getting interoperability done now that they, you know, they're also moving to change the financial incentives. The CIOs want the data to flow. I think the doctors want the data to flow, but the doctors, of course, are worried about being inundated with too much information.
Sure. I mean, the thing that I guess I can't get my head around sometimes is like, why do we even bother and wait? Why is so much pinned to like the government taking care of this when there's so much going on in the private sector? I mean, being at TELF 2.0 and a couple of the other conferences that I've been to lately, you know, and I'm sure you've seen this too. There's plenty going on in the private sector. There are plenty of hospitals will pilot these technologies. They'll decide what works for their the culture of their particular institutions and what doesn't. They can vet it themselves. Why do we need to have this? Because seeing as how difficult it is to get so many different parties with so many different priorities to agree.
Well, the short answer to that is Medicare is the largest payer, and private payers often don't act until Medicare does.
I guess that is a pretty short answer.
Yeah.
Okay, well, let's look at some of the other other priorities for 2015. I mean, telemedicine is among them.
Yes.
It seems like there's been a lot of things happening this year on the telemedicine side.
A lot of things even happening this week. Notably out in LA today, at the USC Center for Body Computing conference, which I wish I were at, but I'm not. I've been to 3 times in the past. Dr. Leslie Saxon, who runs that center, talked about what she called the next, I think the next evolution. That wasn't her exact words, but the future. I believe the future of digital health. She called it I believe the future of digital health, and that's telemedicine using avatars, using virtual doctors, using even holograms. And there's some videos on our site along with the story. You should go check those out. Those are super cool videos that are backed by clinical decision support. These virtual doctors are backed by clinical decision support, which takes out some of the inherent bias that clinicians have. Now, it also may take out some of the judgment skills of doctors too, but let's face it, healthcare is not very safe as it is right now. A lot of errors still get made. She does have a point that there is inherent bias, that surgeons will disproportionately advocate for surgery. Oncologists will disproportionately find cancer when it may or may not be there, that sort of thing. So, people have their biases, and that's what they look for. So, that's one step past telemedicine with just a one-on-one video consultation between a patient and a doctor. This brings in the computer as well, the clinical decision support that's
Sure.
behind it. And then another thing that happened this week, showing that there are now a lot of the telemedicine, the direct-to-consumer telemedicine vendors have been making deals with payers.
Mm-hmm.
Or making deals with pharmacy chains lately. This week was a fairly big one in that American Well signed a deal with Intermountain Healthcare, which is, let's face it, they're
integrated health system, right?
a huge integrated health system that commands a big part of its market in Utah. And the fact that they're incorporated, and Utah has is a very big, very sparsely populated state. Telemedicine makes sense in places like that when people have to travel long distance, and providers are realizing this.
Sure. And also given, I think, news that our colleague Megan Akeshavan had about Walgreens working with MD Live to integrate telemedicine there. Do you think that we're coming to a point where physicians, where CIOs, I should say, of hospitals see kind of retail telemedicine groups like that less as a rival and more as a, well, that's one option, and what hospitals are doing, how hospitals are handling their relationship with patients through telemedicine is something altogether different?
I think they still see them as rivals, as competitors.
Okay.
I don't think they really quite see them as partners yet, although some of the walk-in clinics have formed clinical partnerships. I think CVS MinuteClinic has a number of clinical partnerships with several dozen health systems, mostly for referrals, though. Mostly for referrals. Maybe if it takes some of the less acute urgent care out of the hands of the hospital systems and takes some pressure off the ERs, I think the hospitals would be all for that.
Okay. Okay. So looking at the agenda for CHIME, and what do you see on there or don't see on there that you wish was there or wasn't there?
Okay. Well, I'm intrigued by one scheduled for Thursday called "Enabling the Hospital Steve Jobs Would Have Built." That may be just a sexy title, but I think it's there may be something to it as well. You're looking at what the hospital of the future is going to look like, maybe very digital enabled. It's often hard to tell with some of these breakout sessions. I'm not really blown away by any of the keynoters. There's nobody from the CEO Sean Aker of a company called Good Think is keynoting on Thursday. Is that a company you're familiar with? Because I'm not very familiar with them. You cover the startup world.
Yeah, I'm not familiar with Good Think.
Okay, and then so the keynoters aren't really blowing me away there. Some of the breakout sessions I think are fairly intriguing. They're talking a lot about, there are going to be some good case studies there. MD Anderson, for example, is going to be talking about its advanced analytics. Some other hospitals are talking about how they get to stage 7 on the HIMSS EMR adoption model. Some are talking about things such as optimizing their health IT for patient safety. There's going to be a provider, very much so, and I think advanced analytics that MD Anderson's talking about fits into that as well. But since we've gotten past, now that we're moving into stage 3 meaningful use, or at least now that the rules are out, although they're not going to take effect now until 2018, although if you optionally can start in 2017, you only have to report for 90 days instead of for the full year. I think there's the incentive to do that. It's still a ways away, but there are plenty of other imperatives out there for optimizing EHRs, even if it's not just meeting the meaningful use requirements. And obviously quality improvement is one. Meeting the new demands of value purchasing is another very big one.
Who don't you see on the agenda? Who would you want to see as a keynote? That's
who don't I see on the agenda? I don't see any of the feds, which is unusual.
Because you've been going to this conference for a while, so that's unusual not to see someone from the federal government being a keynote.
As a keynote, or either either the national coordinator or somebody, some top official from CMS or something like that.
Do you think that has anything to do with the fact that we're about to enter an election year?
No, I think it's just that maybe they either the schedules didn't work out for somebody. Wait, I take that back. There's a 7 a.m. session on Friday with ONC's Chief Health Information Officer. And I can pretty much tell you the chance that I will be at the sunrise session at 7 a.m. Is less than 1.
I know the Chief Privacy Officer for the ONC spoke at Health 2.0, and she was a really interesting speaker. I know she made some interesting points. Yeah. It seems like this would be a great opportunity for her to speak, but I guess she's probably spoken at this event in the past, right? Or is she too new for that? No, I don't think she's too new for that. She's been around there. She's been around there for a while. I can't say for sure if she's spoken at the event or not, but everybody, all the CIOs are aware of HIPAA and the privacy rules, even if the CEO is still, or somebody else in the records department is preventing patients from getting copies of their records using HIPAA as a convenient excuse, even though HIPAA says pretty much the opposite of how they're applying it. I think all the CIOs know that. I think it's important maybe for Joy to speak at something like Health 2.0 because startups may not know. Sure. So they'll be at the conference. They'll be talking in the hallways about the interoperability roadmap. Yep. And do you think the patient identifier issue will get much mention? I think that is a big part of interoperability because you have to be able to positively identify patients one way or another through a master patient index or since we know there's not going to be a national provider identifier, even though a lot of CIOs are now thinking maybe we should have it. Certainly going into an election year, it's not politically feasible. It's not going to happen, especially with a divided government right now. There's no way that Congress will vote for and the president will sign anything funding implementation of a national provider identifier that Congress specifically blocked in 1998. Right. Yeah. So no progress there. None. Okay. Okay. Well, outside of CHIME's, just looking beyond what you've been covering this week, what was a story that you particularly enjoyed or that you thought was a big priority this week? Well, obviously, I was sort of nose down in the in the policy being inside the Beltway for several days, and with the Stage 3 rule coming out, I know we're trying to diversify. I have a directive to diversify my coverage a little bit and not be so heavy on the policy and be a little bit more on what the providers are doing. I will pick a lot of that up at CHIME next week. I have a good one that I have done the interview for and will report on hopefully early next week before I go to CHIME. I think Megan is reporting from the events that she was at really blew me away. I mean, the Walgreens story is really good, and that's not a topic she knows much. She never covers telemedicine. It never covers the pharmacist. Sure. I mean, but she. Although digital health is getting into the pharmaceutical industry. Absolutely. A huge amount. Your piece on picking 3 people you'd like to see on Shark Tank was pretty cool. Yeah, that would actually be interesting if it actually goes anywhere. Yeah. But So you think Dr. McDreamy, Dr. McDreamy should be that? I mean that was what? Dr. McDreamy. McDreamy.
Yeah.
Yeah, he's kind of, that was more sort of like the sort of the crowd pleaser, the sort of the mass market crowd pleaser, because obviously he's, his nickname is Dr. McDreamy.
Yeah.
McDreamy, Dr. Dreamy. But he's invested, he's been an angel investor in at least one health IT company, and he's been involved in healthcare. I think he set up a foundation in Maine because after his mother had ovarian cancer. So it's obviously an area that means a lot to him personally. And now I think a spoiler alert, I think he's no longer on the show. On Grey's Anatomy. Yeah.
I wouldn't know. We'd have to call it a pop culture expert here.
But so he'll have plenty of his time on his hands to invest and focus on investing.
Yeah.
But one of the stories that I enjoyed covering this week was one that I picked up at the Health 2.0 conference. And it was AARP is following up on a report it did, a study it did earlier this year, assessing caregiver needs, and they're doing a deeper dive on that. They're actually going to be following up a report they did called Health Innovation Frontiers with something similar, but focusing on caregivers' needs, identifying, I guess, around 7 areas where they see opportunities for technology to address the needs of caregivers. And one of the reasons why they want to do this, I learned, was from AARP Director Jeffrey Makauka, is that there's a lot of health IT technology that is aimed at caregivers. No one company has seen a lot of resonance with caregivers, and so they want to kind of plow that area to get a better understanding of why. So the plan is to release that at the Consumer Electronics Show in January next year. But they're also planning to do a survey of caregivers, because there are a good few of them that are millennials aged 18 to 34, and as well as Generation Xers like me. And they want to better identify, for those who spend at least 8 hours a week or more caring for a senior, what the kind of activities they're doing with them are, and where technology could potentially help in that respect. So cool. So it's been a very big week for all of us, I think, as far as new developments and
I mean, you had
stories.
some interesting news with Pocket Doc, with Health Catalyst.
Yeah, and you as well, being knee deep in Washington with the Interoperability Fund.
Yeah, and speaking about interoperability and about patient ID, I was just reminded via Twitter that CHIME earlier this year issued a $1 million challenge to create a national patient ID somehow, whether it's through the federal government or some other means. I'd like to see what kind of update we're going to get out of that, whether any progress has actually been made.
Sure.
So
okay.
Yeah.
Well, I guess I think we'll conclude our show now.
Yeah.
Thanks for joining us on MedHeads. I'm Stephanie Baum, in this hopefully next week back in Philadelphia, and digital health editor with MedCity News, and I've been joined by Neil Versel, our health technology reporter, and follow his coverage of CHIME next week.
All right,
have a good weekend.
Have a great weekend.
Thanks.